Hi, my name is Rachel Hazlitt, and today I will be presenting our research titled An Electronic Medical Record Study of the Rate of CT and MRI Scanning of Female Victims of Non-Fatal Strangulation for Identification of Brain Injury. I'm excited to share our research focused on brain injury identification because this work stems from a significant issue within the context of intimate partner violence, formerly known as domestic violence, which affects approximately 10% of women in the United States through forms of violence such as choking or suffocation. Non-fatal strangulation is a particularly severe type of intimate partner violence. This is defined as external pressure on the neck and can potentially lead to hypoxic injury, including traumatic brain injury. While brain injuries are best identified through advanced imaging techniques like CT and more optimally MRI scans, there is currently no standardized care pathway for these women. Clinicians determine the medical necessity for scans based on clinical judgment, leaving the extent of diagnostic imaging during treatment unclear. Our study aimed to assess how often female patients with a diagnosis of strangulation from assault received CT or MRI scans to evaluate for brain injury. Using Cerner, a national repository of de-identified medical records that is HIPAA compliant, we analyzed cases flagged under ICD-9 codes 994.7 and E963 to include asphyxiation, strangulation, and related injuries. We focused on women aged 13 to 65, and our data collection captured the use of CT and MRI scans, as well as care settings such as emergency rooms, observation units, and outpatient clinics. From a sample of 160 patients with a mean age of 32, we found that most received care in the emergency department. However, the rate of CT and MRI use was alarmingly low, indicating a significant gap in diagnosing potential brain injury in this high-risk population. Despite the vulnerability of this population, many of these patients were not provided with the advanced diagnostic measures necessary to detect underlying injuries that might not present immediately or externally. Our findings suggest that educational interventions are critically needed. Discharge materials for non-fatal strangulation survivors should include information about the signs and symptoms of brain injury and emphasize the importance of follow-up care. Additionally, our next steps involve expanding the scope of our study to include a broader range of non-fatal strangulation-related ICD-10 codes. This will allow us to gain a more comprehensive understanding of gaps in care and ensure future research informs the development of standardized care protocols. Finally, we would like to acknowledge the Domestic Violence Intervention Services, Dr. John Lowe and Dr. Scott Shepard for their contributions to this research. Their dedication has been instrumental in shedding light on this underrepresented issue. Thank you for your time and for your attention, and have a great day.